Thank you very much, and thank you all for having me back again. It's always a pleasure to be back here in the kingdom. And to those of you who are yawning at the thought of a legal and ethical lecture being the last one of the day, we're going to try to make this interesting. So bear with us. And there is, a lot to cover here. Just as a kind of quick poll of the audience, how many of you here spend at least 50% of your time taking care of patients with gynecologic cancer? Okay. And how many of you spend at least 50% of your time taking care of obstetrical patients? Okay. All right. So I'm going to do a brief overview of some of the kind of issues involved in legal and ethical concerns regarding obstetrical hemorrhage, taking time to go through kind of why it's important to define the problem and define the outcomes, which from the standpoint of kind of operating within legal and ethical boundaries, you need to kind of know the problem and know the kind of regional standard of care. Talk a little bit about systems approaches both in the United States and particularly at the University of Cincinnati. And by systems approaches, you refer to changes that have become, particularly popular in the United States, certainly other areas of the world as well, with some kind of variable uptake in U.S. institutions. Hospital administrators tend to be very fond of systems approaches. Part of that in the U.S. is because it diffuses legal responsibility a little bit from providers and institutions by having a system in place. Providers in general have been a little bit resistant to systems approaches in many cases because it tends to create algorithms, and people tend to worry that individual patient concerns aren't being attended to. I want to make an argument today that obstetrical hemorrhage is a case where a defined systems approach really can make a tremendous difference, in the same way that, at this point in time, none of us really argue that medical resuscitation should not be handled in a systematic fashion. Obstetrical hemorrhage should be viewed in kind of a similar light regarding these concerns. And then finally, I'm going to talk a little bit about some considerations in patients who refuse blood transfusion, which certainly is a small but important patient population in the United States, and many of you may have patients where that's a significant concern as well. So obstetrical hemorrhage, we can all agree, occurs consistently. We know the risk factors, yet we're relatively poor at predicting for an individual patient whether she's going to have a significant bleed. Knowing these risk factors are usually of fairly limited ability to predict this occurrence. So even though significant maternal hemorrhage has a low incidence, it is somewhat increasing, and the incidence has been reported anywhere from 1 to 5% of deliveries based on the criteria that are used, and that's about 3% in the United States. We've heard a number of good talks, and I'm going to review briefly some of those things as well about morbidity from obstetrical hemorrhage. But certainly peripartum hysterectomy is a significant morbidity, obviously. Average is probably about 3% of women who have significant postpartum hemorrhage. But certainly organ failure, thromboembolic disease, some kind of less common complications like Sheehan syndrome and others are significant morbidity. And then maternal mortality from postpartum hemorrhage ranges from less than 1% to as much as 20% in certain patient populations worldwide. The average is approximately 2%. So when we talk about a legal and ethical framework, it's important within an institution or within a region to define what we mean by maternal hemorrhage, and we've talked a little bit about this already, and what counts as maternal morbidity. We need to define institutionally and regionally what we consider the standard of care of practice. And if obstetrical hemorrhage will predictably happen, we need a system in place in order to limit severe maternal morbidity. And there are a number of systems that have been proposed, published, some with kind of data to vet the system, some kind of mostly based on expert recommendation. These include the Texas Children's Hospital Flowchart, which was one of the earlier ones. The American Congress of Obstetrics and Gynecology has a 4-stage system. And then I'm going to spend a little more time today talking about the California Maternal Quality Care Collaborative 4-stage response measures, because I do think of the existing systems out there, that is the one that I think most broadly incorporates a large patient population in the state of California. For those of you who may or may not be aware, population is about 40 million people, and these are measures that were instituted statewide. So it's vetted within a relatively large system, and as such, more broadly applicable than some other systems. So let's talk a little bit about defining the problem and the outcomes. You've seen a lot of this information already today. Historically, we've defined postpartum hemorrhage by the amount of blood that's lost, and there is some kind of variability there. 500 milliliters for vaginal delivery or 750 milliliters for a cesarean section is the average, and that's historically what we've used to define kind of when we start to get into hemorrhage territory. Variable definitions by the WHO, ACOG. I think there's a growing acceptance at this point that while it's important to be aware of the amount of blood loss and to track that, it's the development of hemodynamic instability that is generally letting us know when we're already behind, and it's the outcome of DIC that we're trying to prevent. There are many ways to measure blood loss, but generally the two categories are kind of visual identification versus what kind of is in the U.S. known as QBL, or quantification of blood loss. More and more institutions in the United States are going over to QBL systems, and that's partly because hospitals have invested in the technology for this. And certainly in this California Maternal Quality Care Collaborative, they did standardize this QBL process across all their sites. We know that we're very poor at estimating blood loss with large volumes. As Dr. Al-Qadri had said earlier, we get worse at predicting it when the blood loss is higher. But in general, we consistently underestimate this. Every case of maternal death in the state of California from hemorrhage showed that the blood loss was significantly underestimated initially. Yes, we get better at estimating blood loss as kind of directed training is instituted, but those gains tend to be lost over time, and even kind of in the best scenario, we're still poor at predicting that. It doesn't seem to be related to how experienced the provider is. So in this sense, it kind of, in general, because we tend to underestimate, we tend to deny that hemorrhage is occurring or that a significant intervention needs to happen. This leads to delay, which, as Dr. Herzog so eloquently highlighted in his talk, is the big problem here. Time is our most valuable commodity when it comes to when we're looking back at a case where a mom had a significant hemorrhage, and these delays lead to morbidity that could be avoided. And so part of the reason that getting familiar with these quantitative blood loss methods as a routine standard for patients who don't necessarily have hemorrhage is that it allows us to recognize in the cases where it does that we're maybe later in the process than we thought we were. So with this routine QBL, the goal is not to have a kind of perfect estimate of blood loss, but to have a more standardized way to quantify that. It seems to be more accurate than our visual estimated blood loss, and I think the reality here is that it's less dependent on a single individual deciding that, since we know that there's so much variability there. It's arguable whether it allows for earlier recognition, but the goal here is to avoid delay in managing excessive blood loss. So the American Congress of OBGYN and the Society for Maternal Fetal Medicine in this most recent obstetric care census number 5 defined what they view as severe maternal morbidity. And I think we can all agree that if the goal is to prevent DIC, then these are kind of steps along the way that allow us, that the majority of which we can agree are severe morbidity. So those include kind of greater than or equal to 4 units of packed red blood cells, 2 units of packed red cells, plus 2 units of FFP transfused if it's not judged to be over-exuberant transfusion. You can see on the kind of across the way on the not severe morbidity, you're allowed to have 2 units of packed red blood cells and 2 units of FSP if they judge the providers were over-exuberant in their ordering a transfusion. Less than 4 units of blood products and pulmonary congestion requiring greater than 1 dose of Lasix. Only a couple units transfused if a uterine balloon or uterine artery compression sutures were placed. Return to the operating room for any major procedure, not including kind of dilation to remove products. Any emergency or unplanned peripartum hysterectomy, including all accretas, even if it was planned ahead of time. Any case requiring uterine artery embolization, and any patient admitted to the ICU for invasive monitoring or treatment, not just for observation. So if we've defined kind of what we want the outcomes to be and kind of generally what we think the problems are, let's talk a little bit about, in a little more detail about the systems approach. So this again is from that California Maternal Quality Care Collaborative with a 4-stage system. And it involves, prior to admission, assessing risk in all patients, and then having kind of successive stages that you can move through with interventions that are tied to those stages. So, all births kind of get stage 0 interventions. You start to institute kind of more attention and providers involved when you start to move up to stage 2 and especially to stage 3 when your QBL exceeds 1,500 milliliters. Let's see if this goes. And this, for the state of California, is what they developed as their algorithm. I don't expect you to be able to read this. The point is not, this is a published system, and I'm not going to go through it in tremendous detail. But the point is, they developed an algorithm that's very much like a code algorithm for medical resuscitation, so that when a patient, every patient kind of starts on the pathway, and when you start to trigger blood loss above a certain level, then additional layers of emergency management are incorporated so that it's done in a systematic fashion, with the goal being to avoid a situation like DIC, which leads to severe maternal morbidity. Every hospital needs to customize the protocol to some degree, but the point is to have a protocol in place that people are aware of and to take a proactive stance in monitoring this problem. So the 4 kind of R's that they incorporated in their safety bundle include readiness, recognition, response, and reporting systems. I'll talk a little bit about what those are. So readiness includes on every unit having a hemorrhage cart with procedural instructions, having rapid access to the hemorrhage medications kind of there physically on the obstetrical unit, to have a response team that's identified with kind of systematic training and roles, and to establish the transfusion protocols. Again, for every patient, recognition involves assessing their initial risk. We know that there's some variability in our ability to use those risk factors to measure cumulative blood loss, and to have active management of the 3rd stage of labor, as has been detailed previously. For every patient with hemorrhage, the response involves kind of the standardized OB hemorrhage emergency management plan with a checklist and roles for each of the providers in the same way that a medical resuscitation has people with defined roles, recording the time, recording the medications that are given, and to have an algorithm to do that. The reporting systems and learning include kind of ongoing education with huddles, either kind of with the providers, either kind of for high-risk patients or immediately afterward, post-event debriefings to review what went right and what went wrong, and to review all stage 3 hemorrhages, the ones that are more than 1.5 liters of blood loss, for systems issues that can be modified for quality improvement in the future. So why do we need this? Well, we know the incidence is increasing. Most hemorrhage deaths, when they're gone back and re-reviewed, have a high ability to have been prevented had other interventions been included. And generally the severe morbidity, patients with severe morbidity, we can identify kind of breakdown points in communication that are better managed by a team approach. So some of the examples from their system include kind of these pre-admission risks. So patients who are at low risk, they might kind of only have blood clot on file for blood type. Medium risk, you may have a type and screen done at initial, and then for high risk patients, you may have units that are cross-matched. These include, many of the risk factors that we talked about earlier. Previous uterine surgery, whether it's a singleton or multiple gestation, number of prior births, other medical conditions that may increase the risk for bleeding, previous history of postpartum hemorrhage. The medication recommendations for the use of oxytocin we've discussed earlier today, and certainly for prevention of hemorrhage, the use of this is very standardized. For the treatment of hemorrhage, also as such, we talked before about how all the second-line hemostatic agents have similar efficacy, and I do think it's worthwhile to choose a standard second-line agent, whether that's a kind of consensus by the providers at a hospital as to which one they like best to have, but to have that readily available so that there's no delay in getting those medications when needed. It seems kind of trite to necessarily have a specific cart, but I do think it makes a big difference. Certainly for medical resuscitation, having a crash cart with all the necessary items that you need in easy access to and kind of filled in a standard fashion has significantly decreased the morbidity from medical resuscitation. And in the same way, I think these cases need to be viewed similarly, so that these carts are available, they're set up in a standard fashion, the team is familiar with kind of who's responsible for which items in that cart, that it's restocked frequently, and that the physicians and nursing staff are familiar with their use. Up here? Those are the stage, what they're doing is reviewing, actually it's kind of an abbreviated version of this. So they're reviewing kind of the criteria for the stages, and then what are the role, and so kind of on this slide I'm going to talk a little bit about kind of, so this is an example of their stage 3 OB hemorrhage card. So this would be cumulative blood loss greater than 1.5 liters, greater than 2 units of pack cells given, vital signs unstable, or suspicion for DIC. So kind of the most extreme case. So 3 columns: mobilize, act, think. So the nurse or physician activate the massive hemorrhage protocol, and the phone number there, the person there. And then for the charge nurse or designee, charge nurse or kind of nursing lead in charge, notify the advanced GYN surgeon, notify the ICU, have a second anesthesiologist if necessary, alert the OR, ensure that the hemorrhage card's present, so on and so forth. Alert the blood bank to prepare additional blood, In terms of acting, you identify a team leader, which is frequently the obstetrician, in combination with the OB anesthesiologist, initiate a massive hemorrhage protocol, move to the operating room if you're not already there, and then kind of consistently repeat necessary labs every 30 to 60 minutes. For the anesthesiologist, make sure that as indicated they have the necessary line support, etc. For the primary nurse, these are his or her roles. Second nurse or anesthesiologist, third nurse, but having kind of the team members that are necessary and defining their roles. And then in terms of kind of things to review or think about, selective embolization, prevention of hypothermia, interventions based on etiology. If you're not already back in the operating room, do we need to consider operative intervention? Medications used for unresponsive coagulopathy, but I do think that the specifics of this system may not be ideal for every institution, but I think the point is that there's a group of people who are familiar with the problem and educated about it, who are coming up with a plan as to what they think is the right way to approach it, doing that in a systematic fashion, tracking their outcomes, having debriefings afterward, and doing quality improvement initiatives in order to improve the outcomes. So most maternal morbidities, mortalities and near misses due to hemorrhage are preventable, and that's kind of the legal/ethical bend to this is a systems approach to these problems allows the institutions and providers to have a better framework to justify legally how outcomes the outcomes that resulted, and allows them to make improvements that hopefully decrease that risk. So we know at least a third of patients will have no risk factors for this prior to labor, but to have it in place for every patient, hopefully limits the associated morbidity. This system is one that relies less on individuals, but more on a team approach, and therefore is less dependent on kind of who's on call for the day, and is more reproducible. So our system at the University of Cincinnati is not nearly as well refined at this time as the California Maternal Quality Care Collaborative. But over the course of the last 6 months, we've started to address much more seriously this issue in a systematic fashion. And I think part of the reason for not having a strict systems approach ahead of time were many of the criticisms that I said before. Individual providers worried that their autonomy to manage things the way that they wanted to wouldn't be cared for well. Some sense from our department leadership that we didn't really want to have too many algorithms and ways that people had to be told to do things. But I do think that we see a much higher incidence of maternal hemorrhage at the University of Cincinnati than many institutions in the United States. We have a much higher peripartum hysterectomy rate than any of the rates that have been quoted up here today. And I do think that certainly looking back over the last 2 years of data that we reviewed of maternal hemorrhage at our institution, we have a long way to go in terms of improving outcomes. So we have this kind of QBL system in place, and it is done in a standard fashion. We have a very organized massive transfusion protocol because we have a very busy trauma service. But over the course of the last several months, we've developed a lot of these kind of policies and procedures, made some modifications to what I've presented to you from the California Maternal Care Collaborative, but to a large extent, because a lot of their information has been vetted in a large population, we found that there were that most of those changes were ones that we wanted to incorporate. So perhaps I'll have the opportunity next year to keep you abreast of the changes that we found. But this is certainly that we've started approaching it in a much more systematic way with a process in place to track quality outcomes and think it's going to make a big difference. So let's talk a little bit about patients who refuse blood transfusions. Now, how much of a problem is this here? How many of you have had a patient in the last 2 years who's refused? Not at all? Not at all. Okay. Yeah, because in probably the biggest ethical conundrum in obstetrical hemorrhage in the United States has to do with this patient population that refuses blood transfusions. I'm glad none of you have to deal with that problem. So I'll talk real briefly about that, and then we can kind of stray into some other areas if need be. But in the United States, there's a complex framework for resistance refusal of blood transfusion, and it's not just kind of the second group, the Jehovah's Witness patients, who certainly in the United States are the most visible group that refuses transfusion, but there are enclaves, whether they're cultural, like a kind of true like ethnic cultural, or whether it's just a social cultural reason why they've decided that they're going to refuse transfusion. So certainly in Cincinnati, it's important to kind of retain a certain amount of cultural humility when we're trying to understand the decision making for these patients, because it isn't a kind of universally accepted single reason that they all refuse. Jehovah's Witnesses, there's about 8 million practicing members worldwide. As a group, they generally allow modern medical care except for transfusion. Their aversion to transfusion stems from their interpretation of Scripture, but most of them are prepared to die rather than accept transfusion, with some exceptions. So there is a little bit of variation in interpretation, and we have a large Jehovah's Witness population in Cincinnati, and I've had many patients at this point who are Jehovah's Witnesses, and they're not all completely identical in terms of what they'll accept and not accept. The most devout witnesses will not accept whole blood or any of the 4 major components, so red cells, platelets, plasma, or white blood cells. Some will accept subfractions, so some will accept FFP or albumin. Preoperative autologous blood donations not acceptable, but technologies that recirculate back to patients may be acceptable for some. So when given the opportunity to be able to explore this ahead of time, and you're not kind of already in a situation where you're getting called in when somebody's 4 liters behind, exploring kind of what are not acceptable to them is an important part of the decision making here. So defining what the boundaries are. This is a lot easier when you develop a rapport with the patient, as I think kind of we can all agree for any complex medical decision making, this is an important piece. There is some variation in terms of what's acceptable to different members of this faith. Transfusion without their consent in the United States has been successfully prosecuted as battery to that individual. There are certainly cases of Jehovah's Witnesses who've decided to accept transfusion and under the guise that it was going to be a confidential part of their medical record and wouldn't be made known to their family members or other members of the community, and then that confidentiality has not been upheld, which has become a big issue. But certainly shared decision making in those situations is important. United States courts have upheld the right of Jehovah's Witnesses and others to refuse transfusion. Oops, missed one. However, pregnancy is frequently should be viewed as a special situation, and we generally do get our hospital ethics committee and our hospital legal risk management group involved when we have a patient who's pregnant and is potentially going to refuse transfusion if there's a outcome, or if there's a outcome that requires it. As a group, they don't generally bring too many lawsuits, but the people who do bring lawsuits are their family members who are not part of the faith. because of the kind of complex set of decision-making about both the mother and infant, there are some guidelines in the United States that are well established and some that are a little more flexible. U.S. courts have upheld a mother's right to control over her own body and by extension to refuse transfusion for herself. However, when her life will likely be lost unless she's transfused, the father or designated guardian should be identified to care for the child. And if a guardian can't be identified, there have been cases where judges have given a court order to transfuse the mom. And as a kind of loophole in their scripture, if ordered by a judge, the transfusion does not technically go against church teaching, and they don't need to be excluded from the community, which I thought was interesting. So, in conclusion, the legal and ethical implications related to obstetrical hemorrhage are related to a kind of local and regional standard of care. It's important to define, measure, and track the incidence of obstetrical hemorrhage, the severity, and the subsequent morbidity. Since many cases are unpredictable, it's important to have a system in place for every delivering patient. The ethical and legal considerations for mothers who refuse blood transfusion are complex, and exploring the boundaries of what's acceptable care for these patients is essential. So with that, I think we have time for questions.